Okay, my name is จตุพจน์พรหมศรีดา
My name is Nantini Wongjan. Now you are in the national panel discussion with the topic of mental health challenges and how to overcome via video conference live streaming. Okay. Now our moderator are in already. So
Okay. at สมเด็จเจ้าพระยา Institute of Psychiatry Ministry of Public Health Thailand
psychiatrist since 2007. He has trained in epidemiology and statistics in mental health research, Institute of Psychiatry, King's College, London. He is also a professional in schizophrenia as he was trained at British Association of Psychopharmacology Clinical Module of Schizophrenia on May 2007.
Okay, now I'm very pleased to introduce the four guest speakers as you see on the screen. Dr. Wendy Lee. She is an associate professor of psychology, associate dean for research, College of Healthcare Sciences at James Cook University, Australia. Next, Professor Brett McDermott. He is a professor in psychiatry at College of Medicine and Dentistry, Beyond Blue spokesperson for disaster mental health, James Cook University, Australia.
And next, Dr. Sarah Hughes. She is a chief executive at Center for Mental Health, United Kingdom. And Dr. Dutsadi Jingsira Kunwit. She is the director of Child and Adolescent Mental Health, Rajnakarin Institute, Ministry of Public Health, Thailand.
Okay, before we begin the session, we should know the participant rules as shown on the screen.
Yes. The thing you must do for participants is keep silent during the presentation. If you have any questions, you can text the message below at the inbox on your screen.
Now it's time for Dr. Sutha Supanya to moderate the session. Continuing, please.
Dr. Sutha.
ดร.สุธานะครับก็จะเป็นคนที่นำการพูดคุยกันในเซสชันนี้นะครับ
Good afternoon, Dr. Sutha. Do you hear us? We could not hear you.
Dr. Sutha, please turn on your microphone.
All right, now we can see you on the screen. And could you say something or respond us? We We didn't hear you. We still not. Huh? Do you turn on the microphone?
We are still do not hear you, Dr. Sutha.
Sorry to keep you waiting. We have a technical problem in microphone. So. Okay, we can hear you. Thank you.
Very early morning for you then, Dr. For Dr. Lee and Dr. We can start the conference. Yeah, okay. Hi. Hi. So
ท่านนะครับโอเคเริ่มกันเลยแล้วกันนะครับสวัสดีดรลีProfessor Brett นะครับดรซาร่าดรดุษฎี
Dr. Dusli almost there, almost here. Okay, so okay, yes, we can start the conference. Dr. Sutha, please. Okay.
ก็ขอบคุณทุกท่านนะครับที่เข้ามาร่วมคอนเฟอเรนซ์ในวันนี้นะครับเราจะมีpanel discussion กันในวันนี้เกี่ยวกับการเอาชนะปัญหาเกี่ยวกับสุขภาพจิตซึ่งเราจะพูดถึงสถานการณ์ทั่วโลกเกี่ยวกับสุขภาพจิตทุกอย่างนะครับในโลกเปลี่ยนหมดนะครับระบบทุกอย่างเปลี่ยนหมดเนื่องมาจากโควิด -19 ซึ่งเราก็จะลองมาดูว่าแต่ละประเทศจัดการกับปัญหาพวกนี้ยังไงหรือการเปลี่ยนแปลงพวกนี้อย่างไรซึ่งหลายๆประเทศนะครับยังมีการยังพยายามสู้กับปัญหาโควิด -19 อยู่แล้วเราก็จะมาลองดูว่าในแต่ละประเทศจัดการกับปัญหาสุขภาพจิตหลายๆประเทศยังไงทั้งสหรัฐอเมริกาออสเตรเลียแล้วก็ประเทศไทยเรามาดูว่าระบบหรือว่าบริการเหมือนเดิมหรือเปลี่ยนแปลงไปอย่างไรหรือเดินไปก้าวจะไปสู่ข้างหน้าอย่างไรหรือมีการปรับปรุงพัฒนาอย่างไรเราจะเริ่มกับดรเวลลี่
Professor of Psychology and also the Associate Dean for Research College of Healthcare Science at James Cook University. She is the founding convener of the Asian Mental Health Research Group and adjunct professor at Shanxi and Taiyuan Shanxi University and Taiyuan, I think, Psychiatric Hospital in China. And her research interests span mental health and well-being, personality and applied social psychology, and as well as aging. She completed her undergrad to PhD education at the University of Waikato in social science and psychology. Today, she will begin the discussion with a short talk on mental health challenge supporting older people through the COVID-19 pandemic. Can I introduce each of the expert one by one before your talk? And then I take the question and then ask you all at the end. Is that okay? Thank you. So to you, Dr. Lee, please.
Thank you. Do we have the PowerPoint? Can you hear me? Thank you so much for the chair for your very kind introduction. I'm Wendy Lee. I am from my home. You can see this is my home, my study. And let me give you some background of what happened in Australia. In my city, I am located in a tropical city with beautiful sunshine of more than 300 days per year. So I think we are one of the lucky cities in Australia. Our city only has a total 23 cases of COVID-19, and we haven't had any new cases since April. I think that's mid-April. Unfortunately, our fellow Australians in the state of Victoria are experiencing very stressful situation because the second wave occurs, and which is much worse than the first wave. So among all those stressful situations, I think older people are facing much stressful situation than younger people. So this is where I am come from for today's discussion to kick off the panel discussion for this afternoon. May I have next slide, please? Next slide, please. Thank you. Can I go back to the previous one? Thank you. And today my presentation is a very short one, so I will cover the impact of COVID-19 pandemic on older people's mental health and what kind of challenges our older people are facing and the initiative to overcome the challenges. For example, what the government has been done, particularly in Australia, and what we can do as psychologists or psychiatrists to support our older people, not only from a clinical perspective, but also from a community perspective. Next slide, please. It's a very, very difficult time for everyone, but it's particularly difficult for older people. Older people are less likely to contract COVID-19 than younger people because they are not as active as younger people, and they are more conscious to protect themselves as well as the broader community. However, they are at greater risk of serious or life-threatening health complications, particularly for those older people who have health conditions before they contracting COVID-19. So they have higher risk than younger people. And moreover, the quarantine measures that are particularly restrict to older people enforce social isolation. While gradual release from lockdown, many countries still maintain protection for older people who are at high risk from COVID-19. As a result, older people will experience a longer period of social isolation compared to younger people. As we know, social isolation is strongly associated with depression, anxiety, and cognitive decline. Social isolation may also reduce older people's resilience, self-esteem, sense of purpose and meaning of life. So it's social isolation have great impact on older people's mental health. And also, the extension media coverage on the infected cases and deaths in nursing home heightened older people's fear of infection and death. And the social isolation in nursing home is much worse than what we are experiencing in our own home. For example, in Australia, the residential aged care facilities will continue to restrict visits by limiting visitor number and the duration of visits. For instance, limited visit to a maximum 2 visitors at any one time per resident, which means the residents' family cannot come together, only 2 members per time, per visit. And no hugging, no cuddling. It's very hard, isn't it? Of course, aged care residents can stay connected with families and friends by phone and video calls. But it's different when we can hug our children, our grandchildren. And no hugging, no cuddling, no visiting. This may be a crazy new normal for our older people who are living in aged care homes. So this is the reality our older people are facing. Next slide, please. And this is the statistic in Australia regarding older people. The blue color indicated the cases, the active cases of older people. And the yellow one, that's the recover cases of older people. And the green one is the number of deaths of older people. And we can see the recovering rate for older people is very, very low compared to younger people. And the COVID-19 crisis in aged care home, as I mentioned previously, for example, let's use Victoria, where the second wave is experiencing. Out of about 50,000 beds in Australia, in Victoria, 5,400 are in the public system. The bed means the residential aged care bed, largely in regional areas. So, which means that the large proportion of nursing homes are private-owned facilities. Private nursing homes are underprepared for medical emergencies such as COVID-19. Next slide, please. So what kind of initiatives we have taken or we would like to take to overcome the challenges that our older people facing? For example, in Victoria and Australia, the Australian National Cabinet established to respond to the COVID-19 pandemic. So this cabinet consisting of primary minister, premiers, and territory leaders of Australia. They have agreed to enhance arrangements to protect older Australia. And in Victoria, COVID-19 plan for the Victorian aged care sectors developed by the Department of Health and Human Services. I attached the link to the plan. This is what the governments in Australia are doing. It's a little bit late. And what else we can do? Next slide, please. As you know, I am a psychologist, particularly focusing on community psychology. And for me, I am working with a group of researchers at our university. We are developing a project, a shown virtual community garden project to promote healthy aging during the time of COVID-19. What we are doing that we have researchers in Singapore, Thailand, and Malaysia, as well as the Philippines. We would like to work together to create a virtual community gardens network. to respond to the social isolation older people are experiencing in the time of COVID-19. This project aims to promote healthy aging by creating a virtual community gardener network, remotely link establish our new community gardens group in the five countries I mentioned previously. Next slide, please. This project will offer opportunities for older people to connect with nature and each other by sharing gardening tips, experiences with peers locally and regionally as well as nationally through this network. This project reflects our 3Cs principle. What are the 3Cs? 3Cs, caring for the nature, caring for the plants, and caring about people, as well as connecting with people and also their families, not only older people, but also their families through a series of activities. I will talk about the activities in the next slide. And through the caring and connection, we aim to create social cohesion. That's the C, social cohesion among the participants as well as their families. Next slide, please. So what we are going to do, we would like to run virtual workshops sharing gardening tips and recipes. We have lots of activities outside to help older people. And we thought that gardening would be a very good thing to do for older people as well as for ourselves. Because when we are not happy, we can talk to our vegetables, we can talk to our flowers. And this will give us some inspiration from our gardens, from our plants, from our flowers. So we would like to organize virtual workshops to share gardening tips. The speakers will be the participants and also some gardening experts as well. And we would also like to organize virtual tours to visit the community gardens. We are not personally visit community gardens, but we would like to organize virtual tours to visit the community gardens and also organize virtual competition for garden design. For example, I post a garden design for one of our participants, but it's in healthy aging, the previous healthy aging project. And we would also like to organize virtual exhibition of community garden products, for example, their vegetables, and using the vegetables for cooking demonstration, virtual cooking demonstration as well. And we aim book on gardening journey as well as recipes. So this is, we are thinking that we can do to support our older people to maintain psychological well-being and mental health through this kind of connection across 5 countries. Next slide, please. And for us, we think we should not entirely rely on government's responses to support older people. We can do our part to support our older people. And the message I want you to take home is together we can get through it. Thank you so much. That's all from me.
Thank you so much, Dr. Lee. That was very interesting presentation. There's a few things I would like to ask, and maybe people would ask, but then can we ask the question at the end? Next up is Professor McDermott. Professor McDermott is the professor in psychiatry at the JCU College of Medicine and Dentistry, and also the Beyond Blue spokesperson for disaster mental health. He was trained in psychiatry and also child and adolescent psychiatry from the UK and in Australia. He is also a fellow at Churchill College, Cambridge University, as well as Mater Research and an adjunct professor at the QUT. He was the executive director of the Mater Child and Youth Mental Health Service in Brisbane, Queensland, from 2002 to 2014, and was a board director of Beyond Blue from 2006 to 2016. Beyond Blue is quite famous worldwide for its work against depression, especially in younger people. And we know, but not you, but personally, sorry, but we have learned about Beyond Blue even when I was a trainee, like a decade ago. So very happy to hear firsthand from people who were involved. And his research interests include mental health system of care with specific focus on individuals presenting with depression, PTSD, and eating disorder. So he's going to tell us a little bit about COVID. How can we learn from this in our talk entitled COVID-19 pandemic? What we can learn from disaster research. To you, Professor McDermott.
Okay, if you could just nod if you can hear me. Can you hear me okay? Fantastic, fantastic. Okay, so firstly, I'd just like to thank the Department of Mental Health and the Ministry of Public Health. It's an honour to be asked. I'm very pleased that you asked me, so thank you very much. It's a very long time since I've been in Thailand, and I'm looking forward to coming back after the world returns to some semblance of normality. That would be very nice. So if you could screen share my slides, please. Fantastic. Yeah. Okay, so the first thing we can see is that COVID has aged me a lot. That's only a picture from last year. It's I'm going grey with this kind of thing that's happening in the world at the moment. Next slide. Okay, so Australia is actually been very good at mental health responses after disasters, mainly because Australia has many, many bushfires, wildfires every year. And of course, the beginning of this year, we were famous around the world for the biggest wildfire we've ever had. Where Wendy and I live in North Queensland, we have cyclones every year. We also have floods. So Australia has had a lot of experience from natural disasters and putting in systems of care after natural disasters. So I want to talk about, is there anything we can learn from that type of disaster and the type of disaster we have at the moment, which is the pandemic. And then at the end, I'll talk about some specific learnings about medical practitioners who are one of the most impacted group that we have at the moment. Next slide, please. Okay, this is a very famous graph from Zunin and Myers in 2000, and it's actually what, in my experience, most disasters looked like. And clearly this was after a natural disaster, but I just want to talk about how we can have some learnings from this, from a pandemic. So in a disaster, there's this pre-disaster phase. It's when, we know that something's going to happen. The Bureau of Meteorology have said a cyclone's on the way, or a bushfire has started and we know that's on the way. So there's this period of heightened concern. And of course, in the pandemic, we have all experienced that. We all saw Wuhan, we saw the terrible things that happened there. And then, of course, Italy had a major response and was in fact worse than the original response in Wuhan. And there was 30,000 deaths, and then Spain and France. And the rest of the world kind of waited in this pre-disaster period of heightened concern. And in Australia, we did incredibly well, and really until the last, say, 3 weeks. Our cases have more than doubled in the last 3 weeks. And I noticed that Thailand has been doing fantastically well. There's only about 3,000 cases in Thailand. Anyway, then it impacts, and there's this phase which is called the heroic phase, and people do amazing things in disasters. They fight fires and they help people after cyclones, and communities pull together and they do these heroic things. Healthcare workers work long shifts and they get a lot of satisfaction about really helping. And that's called the honeymoon period, where people are pulling together and there's an acute stress, an acute threat to society. And everybody knows what I mean. We've all felt that in the last few months. But then this is where things have changed. This is where the model kind of doesn't quite work, because after this honeymoon period, things usually return, or they look like they return to normal. And of course, in Australia, after the first wave, we had this kind of period where it looked like that everything had returned to normal. But what happens after a natural disaster is there's this period of disillusionment. The people who are impacted feel that they've been forgotten and they've been left. And there's this long period where it becomes really clear to the impacted people that the disaster is not over. Financially, they are impacted, and emotionally, they're impacted. And it takes years and years and years for people to get better. Next slide, please. So I'm sorry, this is a little bit of a complicated slide, but I'll break this down so it's actually quite an easy slide. This is a structural equation model explaining child post-traumatic stress disorder after a cyclone. And all you need to kind of consider is the three major big circles. So the first thing is exposure to the trauma. You need to be exposed to the cyclone to get post-traumatic stress disorder. And in COVID, you really need to be exposed directly to the infection to get PTSD. But the way it affects you is through that circle there on the right-hand side, the threat perception. You really need to think that you're going to die if you're going to get PTSD, post-traumatic stress disorder. If you don't think you're going to die, you pretty well won't get PTSD. And if you think you're going to die, the chances of getting PTSD are 5 to 10 times increased. So unfortunately, a lot of our healthcare workers are actually at higher risk of post-traumatic stress disorder. And a lot of the older people and people that went into intensive care and survived the experience of being intensive care and intubation, those things, they're at much higher risk of PTSD if they thought they were going to die. On the bottom right is child connectedness. And this is really interesting. People who were socially connected were at much lower rate of getting post-traumatic stress disorder. And people who were poor connectedness, they're at a much higher rate of getting PTSD. And that is really interesting and follows on what Wendy Lee just said. Her wonderful project about virtual gardens is about connecting people, social connectedness. And our research, I didn't know Wendy was doing this. I think it's a wonderful idea. Our research suggests that connectedness is a major protection for not only social isolation and depression, but also for PTSD. Next slide. So disaster research is really clear that in the acute event, if you have the experience of threat, you'll go on to get potential PTSD or generalized anxiety disorder or panic disorder. if you have a lot of loss, if you've lost loved ones, if loved ones have died, if you have loss of identity at work, loss through separation, you're at more risk of a depression and grief paradigm. If there's a chronic event, like a chronic disaster, like the pandemic in some respects, and the next slide we'll talk about that, the pandemic is like a chronic disaster, then we know that you're much more likely in year 2 and year 3 to have depression, hopelessness, and feelings of suicide. And in fact, in Australia, 2 or 3 years after natural disasters, the suicide rate goes up in those areas. We also know in these chronic disasters that there is relationship breakdown, increased domestic violence, and increased substance abuse disorder. The next slide, please. So my suggestion is we adapt the Kuhnen and Myers model, and we put 2 curves here, and the curves are after the pandemic, a lot of people mightn't have PTSD unless they were directly impacted. But I have strong concerns about the rate of depression and the rate of suicide in the years following. And the red line is people doing very well. So that's low rates of depression and suicide, and the blue line is much higher rates. Now, this is where we bring in some research from the global financial crisis. So there's research in Spain, research from Horton in England, research in America that shows that public policy that maintained levels of employment was very influential in affecting the rate of depression and suicide. So if you had a public policy that maintained people with some work and maintains people's salary or supported the general economy, obviously different countries have more resources and the ability to do that. This actually has a major positive impact on mental health over the next 2 years. So in Australia, which is, you know, a wealthy country and very lucky, we have been at the moment supporting people's wages. So even if you're off work, people have been paid by the government. It's called JobKeeper. A JobKeeper wage is being paying people who have been put out of work. And that's being paid until the end of September. So at the moment, that's been very good. And I think as a public health initiative, it's been there to support the economy, but it has a huge public health benefit. After September, of course, we're very worried that this won't be continued, but hopefully our current lockdown in Victoria will be better then, and our country will be opening up internally and people's employment will return. So there are major financial stimulus initiatives that actually have a strong mental health benefit, and without them, we're very worried about depression and suicide. Next slide. So that really says the same thing. There's the acute pandemic, but then there's the acute recession, and the worry is economic depression that will decrease self-esteem, role identity, loss of role identity, and a purposeful life. And this will increase the rates of depression. Next slide. We heard, so those very kind words about Beyond Blue at the start. Thank you for those. Beyond Blue a few years ago looked at the psychological health of Australian doctors, looked at 11,000 Australian doctors. And one of the concerns we all have to face, and this is people in the room are generally healthcare practitioners, that doctors and nurses and allied health, they had quite a lot of psychological distress, higher than the Australian average and higher than other professionals before COVID. And you can see there, you can see the rates in male and female doctors is higher before COVID. Next slide. and we had very high rates of emotional exhaustion, 47% in young doctors, and very high rates of being cynical prior to COVID. So a lot of Australian doctors were working very hard and feeling close to burnout before COVID. Next slide. And this is some research from a Chinese colleague and Dr. Lee and myself. Prior to COVID, we found that depression depression and anxiety were related and mediated through burnout and secondary traumatic stress and compassion, fatigue and satisfaction. So one of the major concerns that we all have is that with COVID, our healthcare professionals are under more stress. They're more subject to feeling they might, die. They might have higher rates of PTSD. There are high rates of burnout, anxiety, and depression. I think that's a specific group that we really need to be mindful of. Next slide, thanks. So, there's strong anecdotal evidence about this, burnout, working longer hours, problems with protective, PPE, anger about the response. There is some mitigation, and that's, we know that healthcare workers have generally been highly supported. China was able to mobilise huge numbers of healthcare workers to help in Wuhan. We know there's been great public support in Italy and Spain and Australia and USA. I have strong concerns about this. One thing I will mention before finishing, and that is in Australia we have this economic response, but also we've started a peer support network for health professionals. And you can just Google hand in hand, HAND, hand in hand for healthcare professionals. And there's a Facebook page and a Twitter page, and we're launching a website next week. And this is where we join healthcare professionals with each other, and we provide peer support where they can talk to each other and they can debrief and they can talk about their level of stress and what they're doing to mitigate that and work through that. It's preclinical. It's not for people that have mental health problems. It's for any healthcare professional who can talk about these issues. And I think that the early evidence is that peer support and helping each other in these difficult times could be a very powerful national initiative. So last slide. So just in summary, I think there is some useful things we can learn from disaster research. It's useful to think about these phases. It's useful to think about post-traumatic stress disorder in the acute phase and depression, common, in the long phase. And like disasters, I think it's also useful to talk about universal interventions that can help whole of countries and whole of society. So that's enough of me, and I'm obviously very happy to answer other questions later on with the panel. Thank you very much.
Thank you, Professor. That's also very, very interesting, especially on the economic point post-COVID, which we don't know yet when we arrive at that point. Next up is Dr. Hughes, and I must say I'm especially very grateful because it's still very early in the UK, and she joined us here. And Dr. Hughes is the Chief Executive at the Centre for Mental Health UK, which is an independent mental health charity based in London. She's passionate about mental health and also has extensive experience in both mental health and criminal justice systems. And she has been working for more than 30 years. Initially trained as a social worker, she has managed quite many innovative community and secure services. One of the things that was marked in her CV was the first night in custody project started in Holloway prison that was later rolled out across the country. She also has led the CPSL Mind, an organization known internationally for values-led practice and high-impact campaigns, including Stop Suicide and Stress Less. As the Chief Executive of the Center for Mental Health, she has worked with UK government and other organizations on mental health policy, as well as being the trustees and board members of organizations like Agenda Alliance Association of Mental Health Provider, DFA of all other, as you know, Thai people are quite also passionate about Liverpool and Manchester and so on. And also City Mental Health Alliance. She's a fellow at the Royal Society of Arts, Solberg's Global Sing Academy, and also Mental Health Collective. She will be telling us today about her experience in managing mental health system during the COVID-19. To you, please.
Thank you. Thank you very much. I'm sorry that the sun is in my eyes because it is so early in the UK. The sun is just rising next to my office window, so I apologise for that. And you might see a puppy at some point invade, so hopefully she won't be too disruptive. Thank you very much for inviting me along today. I think that I want to start by saying, you know, it's been a very difficult time, hasn't it, for all of us around the world, and it's really an honour to be able to speak to you about our experience, but also to stand in solidarity with our mental health friends across the world who are trying their very best at the moment to make a difference to people's lives during a time of extraordinary crisis. One of my own challenges is not to use PowerPoint, so I'm going to just read a couple of things that I think are really important. I think it's important to start with the fact that in the UK, it's no secret that we have had one of the highest death rates in the world. And at the moment, we're sitting at 46,000 people have died of COVID in the UK as of today. I think we can all agree that that is an extraordinarily high number. And I think we would add to that we have had a disproportionate impact on people from Black and minoritized ethnic communities. And this has been something that I think many of us in the system could have anticipated. All of the inequalities that we experienced before the pandemic have been amplified in a way that we've never seen before. So the fact that we've seen so many Black and minority ethnic people die across the country has been quite a shock to the health system broadly. And I guess I will talk a bit about what we're doing to try and think about that. We've seen some really challenging and worrying things. So as Brett discussed, you know, the impact of crisis, and certainly because families were in lockdown, we saw a massive, a kind of disturbing rise in the level of domestic violence and violence in family homes. We absolutely know that the communication from the government has been inconsistent. And so what we're experiencing right now is a real sense of frustration, I guess. We have lots of local lockdowns, regional lockdowns, quite a bit of confusion. We've had a potential loss this year of about 40% of our NGOs. So our voluntary sector organisations in the community that often support public services are in deep trouble. Many of them rely on community funds, funding that is not necessarily from the public sector. And as a result, and as you can imagine, the economic shock meant that donations into those charities pretty much stopped overnight. And if you look in the trade news in the UK for charities, you will see that very big influential charities are often having to make redundant up to a third of their workforce. At the beginning, we saw a massive increase in the access of, call lines and, online support. But we also saw a decrease in the number of referrals to statutory public services. And I think that was very much because of an anxiety around whether those services could be accessed. People were very concerned about getting the virus. So at the Centre for Mental Health, we've done a lot of work around this, and we're, a lot of work in terms of thinking about forecasting the impact of mental health as we go forward. And again, like Brett says, we've looked at the research that's about previous disasters. The economic downturn of 2008 has been really critical and seminal in terms of thinking about what we do in the future. So we're talking about a rising tide of mental illness as we go forward. You will hear the language of, a tsunami of mental illness. I think it's something much more akin to the way that Brett talked about it, which is it emerges over time in response to trauma and crisis. But what did we see? So overnight, we saw digital transformation in a way that we had been asking for, for a decade. Overnight, some of the barriers that we previously had to embedding digital disappeared. It was quite extraordinary. The government, thinking about the economic impact on mental health, the government did something quite extraordinary and unexpected, which is that they developed probably the most extraordinarily advanced economic package for the workforce particularly. So like Australia, we are currently paying salaries. Our programme finishes in October. It's called the furlough scheme. And effectively, we're paying 80% of people's salaries. And of course, that economic package has been really important. People who were self-employed eventually got money. Things like in our welfare system, conditionality and sanctions were put on hold so that people didn't have to go and, have their welfare benefits stopped because they couldn't get to the offices. We saw a massive number of mutual aid groups develop around the country, communities really rising to the challenge to support each other. We developed an NHS volunteering scheme, again, pretty much overnight. And, we saw within days 1 million people around the country volunteer to help their community during this crisis. It was quite extraordinary. But of course, one of the things that I think, was very difficult about the NHS volunteering scheme was that the desire to help, again, describe that hero, that desire to really be at the heart of this crisis was very, very important. And people really responded to that. But the infrastructure wasn't really there to enable the volunteers to actually be used. So the mental health impact of putting yourself out there to try and help your community and then not being able to actually help has been quite crippling for some people. The government has funded some NGOs to try and support the work that they're doing in their communities, but it's nowhere near enough. And the financial loss that charities will experience cannot at this moment be recompensed by the government. We also developed an online and phone support for our frontline health and social care workers. And this has been really important. But we've also found that certainly from a social care perspective, it's been very difficult for staff to access those services. So look, what do we need now? And I think this is a really important question. Some of the things we need now, we needed before the crisis. And this is particularly important from an equalities perspective. And in the UK, equality is probably one of the top priorities in terms of health policy as we go forward. So some of what I'm talking about is an extension of some of the things that we've been asking for some time. The first thing is a cross-government approach to mental health. We need all departments to think about where does mental health sit in the work that they're doing. So if you are in trade, if you are in transport, if you are in arts and culture, what are you going to do to support mental health in the UK? And we've been asking for that for some time. Now we feel that it's quite urgent. We really need to see evidence that the government is prioritising equality for all. And I think we see this around the world, really, that governments will often develop commissions or inquiries that can go on for some time. In relation to the matter of equality, whilst there is a number of inquiries going on in the UK, the reality is that we actually need to see some action now. So there has to be some urgency, but there also has to be some pragmatic assimilation of the research that we already have to hand. So we have offered the government, us at the centre, we co-authored a new proposition for the government called the New Social Contract. And this was in partnership with the leading mental health charities, but also was signed by up to, I think it was about 55 in the end, other NGOs in the third sector, including housing, domestic violence charities, children and young people's charities, and so on. And what we're asking the government to do is not just to focus on recovery. And this is a really important nuance here around language. We have spent a lot of time talking about the new normal, recovery. How can we get back to where we were? We think at the centre, alongside our partners, that this is an actual, an opportunity like no other to renew rather than just kind of do the same things that we've always done. So there's an opportunity here to really think about how do we navigate our social care systems? How do we cultivate peer support? How can we amplify community development and really try and work from the ground upwards rather than top down, which is partly our traditional way of working in the UK? We really need to see a blended model of services that really does include digital. So we mustn't get into a situation where digital is either all good or either all bad. You know, at the moment, we're talking about digital services as if they are the hero of our times. And to some degree, they absolutely are. But they also have various things about the way in which they're delivered and developed that exclude vast numbers of people. They are not the only solution. We really have to think about what we've learned about good mental health. And Wendy Lee spoke yesterday about, for some people, we've seen an improved mental health during lockdown and isolation. So, for instance, some children in our country who experienced bullying and harassment for being at school, suffering deeply in terms of their mental health, not going to school meant that problem just, disappeared. But again, we know that problem's going to be around the corner. But what can we learn from this time? What can we really take from lockdown that we can take into our future? We must have a nuanced conversation. And I think there is a worry sometimes, certainly from government's perspective, that certainly NGOs might just focus on the crisis and the negative aspect of what happens to people's lives. I really think this is an opportunity to not do that. We really want to see mentally healthy schools that are emotionally literate, that are trauma-informed. And thinking about a trauma-informed approach, we think that workplaces, communities, churches, schools should really think about being trauma-informed for many of the reasons we spoke about yesterday. complex grief, because the numbers of people dying in our country has meant that there are a lot of people, a lot of families in deep pain because of that loss that could go on for some time, complicated by infection control, which meant that they couldn't be with their loved ones when their loved ones were taking their last breath. So all of those things mean that trauma, being trauma informed is about understanding what people have gone through, really being empathic, having compassionate services, but understanding that behaviour is in response to trauma. And certainly from a school's perspective, we're encouraging things like schools to resist excluding children and young people for the next sort of 12 to 2 years because of the impact of trauma. We want to see support for families, particularly around post-lockdown experience, but also managing the in and out of lockdown that we're going to experience over the next 12 months. Childcare, relationships with wider family members. We really need to think about that. And then finally, from my perspective, well, two things. We really do need the government to commit to that economic long-term package. We absolutely know that the biggest threat to suicide prevention and mental well-being is the economic downturn, and we must absolutely attend to that. And then finally, we at the Centre are currently, I am currently chairing a mental health research group on behalf of the Royal Foundation with Sir Simon Wesley from King's College London. And we're doing that to really make sure that we can improve the way in which mental health research is used, both in terms of, how it's funded, what priorities are identified for research, and then how it is implemented and brokered across the system. We know that at the moment in mental health research, it can take a very long time for research to happen, for it to be translated, for it to impact policy and practice. And we really want to change that in the UK. So we've got a massive group of people who have committed to that agenda. The challenge of changing the culture of mental health research is very live in the UK right now. So I'll leave you at that, and I'm very pleased to answer questions and engage in the conversation. But it's fair to say that I think us as a mental health global community have our work cut out for the next few years.
Thank you. And I was just laughing at the last bit because, like you said, we are going to be quite hugely impacted by this, unlike the front line from now on.
Yes.
I do hope that things in UK get better soon.
Yes, thank you so much. That's kind.
Yeah.
Thank you.
Thank you for offering to answer. But before we get back to Dr. Hughes, we have the last speaker, Dr. Dusdi, who is the Director of Child and Adolescent Mental Health, Ratchanakarin Institute, which belongs to the Department of Mental Health here in Bangkok, Thailand. She completed her Doctor of Medicine and Child and Adolescent Psychiatry from Chulalongkorn University here in Bangkok, and also finishes her Master's in Child and Adolescent Mental Health at the Institute of Psychiatry. She is very much involved in public health, public mental health system, especially for child and adolescent mental health for the Thai people. And she will talk today on mental health challenge and how to overcome, especially on this COVID impacted era. To Dr. Dusdi, please.
โอเคครับก็ไปที่ดร. สุดุษฎีนะครับโอเค
Hello. สวัสดีค่ะ Hello. And thank you, Dr. Sutra, for your kind introduction. And today is a very good opportunity for me to learn about mental health status after COVID-19 pandemic in Australia and UK. And we learned a lot of things from two countries which are high income countries. And I'd like to shift a bit to share on our experience start with the graph, the common and popular graph that shows the wave after COVID-19 pandemic. We start with the first wave that people are infected with COVID-19, followed by the second and third wave that chronic patients with other medical conditions are affected by the pandemic. And now, like in Thailand, we come to the fourth wave of COVID-19. Next slide, please. Yes, please start with the first slide. Okay. Yeah, these are the topics that I like to talk today about the impact of COVID-19 in Thailand, the challenge, and overcoming the challenge. And next slide, please. And the next slide, please. Yes, this is a graph that I mentioned that it's about the fourth wave that related with mental health. A lot of them involved with psychic trauma, mental illness, and economic injury and burnout. Especially for Thailand, the country that we imply a more strict lockdown strategy, which caused a higher impact on economic recession. Now we can say that Thailand is in economic recession stage, and with this economic crisis will lead to more mental health problems among Thai people in all spectrum, from general population to psychiatric patient. Next slide, please. So we predicted that in this year, it is impossible for us to keep the suicidal rate at our target when we, like last year. We cannot keep it under 6.5 per 100,000 population. And we predict that if we do nothing, you can see that the orange line, the A line, the worst case scenario, if we do nothing, suicidal rate in Thailand will rise up to 8.8 per 100,000 population, which is about 30 to 40% higher than last year. But if we apply extensively public mental health strategy, we can decrease the suicidal rate to only 8 per 100,000 population, which is still higher than last year, but it is it is better than the worst scenario. The next slide, please. And these are the conceptual framework of mental health impact in COVID-19 pandemic in Thailand. We think about four main things, which is, in short, it is SDSB. The first S is stress. D stand for depression. The next S is stand for suicide, and the last B stand for burnout. So SDS is for our people, but B burnout is for health professionals. We found that the most vulnerable group in Thai society are those four groups you can see under yellow, green, purple, and red ovals. The first group is COVID-19 patients and those who were quarantined in either state quarantine or local quarantine. They were stigmatized, especially in early phase when people do not understand what is COVID-19. And also the impact of the illness, also the fear of spreading the virus and other things. So they are the first vulnerable group in our country. Secondly, social vulnerable group, those in poverty or mental patient, people in institution, something like that. Those people are taking higher risk of developing mental health problems because they are previously more vulnerable. The third group is healthcare staff who work tirelessly almost all the time in hospital, especially in the last couple of months. Luckily, I think because when the COVID-19 spread in Thailand, in my country is much better than a couple of months ago. So burnout or burden of healthcare staff is less than previously. And the last group is general population. Even though there are not take higher risk like COVID-19 patients or social vulnerable group, but because of the economic depression will last longer than we expected. So even though today they are general population, they got the impact of economic crisis. So they are one of people that take the risk of mental health problem. Next slide, please. And since we are in middle income countries, so mental health care or mental health service system in our country, in my country, is not quite advanced like in some other developed country. So not only the impact of COVID-19, but we also, in our previous status, it has some challenges in baseline. So we will see what kind of challenge that middle income country like Thailand face. Let's see in the next slide, please. Yes. According to Professor Tonikoff, like 9 proposals of Professor Graham Tonikoff about community mental health trend in 2010, you see that these are 9 challenges in community mental health and also in public mental health. The first thing is about coverage. Also, not even in middle income countries or low income countries, but even in high income countries also have some kind of mental health gap. But the gap in low and middle income countries is higher or wider than in high income countries. You see that because of our people increased life expectancy. So we found more mental health problems in the aged population or the elderly. We found that reduced stigma and discrimination is an important issue in the next decade. Developing accessible and acceptable mental health care will increase the quality of life and also quality of service for our people. Balanced care model is another thing that Professor Tonikoff mentioned. Balanced care is when you balance the care in hospital and also the community care altogether. So we do not put more focus on either hospital or only community-based care, but in balance or in integrated of both hospital and community care. Investing in effective intervention is another thing that Professor Tonikoff mentioned, because generally in politics, they always, especially in consumerism era like this, many of the politicians try to pick up or implement the policy that is easily to implement, but not for sure about the efficacy of that kind of intervention. So what we need is to invest in evidence-based intervention rather than easily to invest or easily to implement intervention. The next one is to improve shared decision-making. Shared decision-making will happen only when people have power. In low and middle income countries, especially where illiterate people, where there are a lot of illiterate people will not be able to making decision or sharing the decision in public perspective or in public issues. The next one is partnership in integrated system, and the last one is recovery model. These are the 9 topics that Professor Tonikoff focused, and we will see in the next slide, please, that these are the pain points in low and middle income countries across these 9 proposals. You see that even though we'd like to close or narrowing the gap, we still have quite wide gap. For example, like depression in Thailand, 10 years ago, only 5% of people can access to mental health care. If they, only 5% of depressed patients can access to mental health care. After 10 years of working hard to increase accessibility of depressive patients to mental health care, the number is rising up to 50 to 60%, but it is just above half of them. So it left almost half of them untreated and increasing the risk of suicide. And even though we'd like to narrowing the gap, even though we have more and a lot of, I would say, increasingly number of mental health care staff, it is still limited and it is poorly distributed. For example, of child psychiatrists in Thailand, we have about 200 child psychiatrists for 12 million children and adolescents in the country. And among these 200, more than half of them work in Bangkok or in central region, and left only 10 to 20 or 20 to 30 child psychiatrists in the northern or the northeastern or the southern part of Thailand, which is the gap is not only for the treatment, but it is also the gap between healthcare staff, mental health staff in central area and in rural area. In terms of aging society, countries like low and middle income countries generally have inadequate psychosocial support for the elderly. For example, the nursing home or nursing care institution for the elderly, we can see that we have limited number of high quality nursing home or nursing care institution for our age population. In terms of stigma and discrimination, we see that because of our cultural belief, we do not have a kind of critical thinking that we can criticize that this is mental symptoms rather than character or personality. So we believe that they are mad or something like that. And we believe that it is kind of supernatural thing that happened to that people rather than it is biological disorder or mental disorder. And also mental health literacy in our country is not quite adequate, I would say. We still need a lot more space for increasing people's mental health literacy. For mental health service or mental hospital, we have around 900 community hospitals around the country, and almost all of them, I would say all of them have psychiatric drug to enough to basic, I mean elementary psychotropic drug. That is enough for providing for major psychiatric disorder. But still, we are a lack of mental health care staff in community hospital, and especially in COVID-19 pandemic. It is not convenient for people to leave their house to transport to the hospital, especially if they need to transport to the hospital that's far away from the house. For example, nowadays, the transportation like the airplane or the train do not operate all full option like before the pandemic COVID. So it is difficult for them, in some of them, to access to the service system that they would like to access to. And for the balanced care model, actually comparing to high-income countries, this is quite compatible. I mean, it is. We can. I would say that community cohesion is a good point and strength of low and middle income countries. So balanced care model in our country is possible and is one of a good direction for us to strengthen this system, and so we can work all together between the hospital and the community all together. In terms of investing in effective intervention for low and middle income countries, we may not be able to invest to very high quality, even though it is effective intervention, because of it is too expensive. So what we can do is we can invest in affordable intervention. So the point of low and middle of the countries in like Islamic country is that we need to identify what is an effective, affordable mental health intervention that we can apply into our country. Even though it is not the best from the evidence, it cannot even though it's not grade A, it can be grade B, but it is B that we are affordable. So it will work in our country. In terms of making sharing decision, human rights and people power will still be a problem in our country. We need some time before people are aware of human rights and before people will be more assertive to raise the comments or discussion to the public in the public issues. In terms of integrative between stakeholders, we found that many of the systems are still centralized into the central part, and we can see that some systems do not have decentralized service. And we found that some of them, even though they have decentralized service, it is fragmentation. So it's still more things to develop in our country. And also for recovery model, we do not have adequate resource for that. And these are the pain points in the Islamic countries. Next slide, please. So in a nutshell, we found that for post-COVID-19 mental health challenge, we found that the treatment gap become wider due to hard-to-reach mental health service. We found that the incidence of mental health problems increasing due to socio-economic disruption. We found that digital disruption left the people who live in lower socio-economic status far behind. And we found that shortage of resources in mental health care due to economic depression. Next slide. So how to overcome these challenges? Next slide, please. Next slide, please. Yes. For closing the gap, we proposing that we need to redistribute mental health workforce because of better transportation system after the COVID, I would say. It will enable that we can matching urban mental health resources and rural mental health needs. Like we can allocate mental health care staff from urban area to rural area just in periodic of time. They do not need to live in rural area, something like that. And even so in COVID-19 pandemic, if they can't transport, we can also provide higher quality, accessible psychiatric services by telemental health between expert in urban and also healthcare staff in rural area. Next slide, please. And because of this digital disruption, digital supported mental health promotion and prevention is also a key solution. But if we do not left someone behind, we need to develop a hybrid model like on-site, online, on-air strategy for mental health promotion and mental health literacy promotion. So if you provide only online or on-air strategy solution, people who cannot access to the internet will lose this opportunity. The second thing is online self-help group. We can bridging the resources and needs within online communities that they can support each other in online platform. Another thing is the smarter mental health chatbot, like the WHO starts the STARS project in that will finish this year. It is a mental health chatbot for adolescents, which can be another mental health intervention that can improve adolescents' mental health status. Next slide, please. Also, in terms of public mental health strategy, we need to identify what is the cost effectiveness strategy. It could be the evidence-based, low-intensity, earlier intervention. We talk a lot about early intervention, but in the crisis like this, we need to implement it earlier than what we expected to do. For example, if we expect to provide it in early adulthood, we may need to step one step backward to late adolescent age group. So to prevent the problems rather than waiting until the problems arise or waiting until they were diagnosed and then just treated, it will take higher cost. And the second thing is that we need to develop to deploy implementation science. Implementation science is a science of implementation. It will change from diffusion and dissemination to implementation. In case of not using implementation science, we may get only 14%, even though we work for 17 years. But if we implement with implementation science, we can get higher up to 80% only within 3 years after implementation. So we need to deploy these implementation science more effectively in our country. Next slide, please. And for the COVID-19 pandemic, this is a C4 plan. It's about combating fourth wave of COVID. That we, as I mentioned, that we need a low intensity, affordable, and earlier intervention. That's why we inject mental vaccine in either individual level, family level, and community level to our people to prevent mental health impacts from COVID-19. And next slide, please. This is in Thai word. We believe that we believe that Thai society can move forward if Thai people are mentally healthy. Thank you. Thank you for letting me share some ideas and discuss about this.
Thanks, Dr. Dusdi. To conclude, it's very interesting that although all of you are from 3-4 different countries, two states of the country, but the COVID has produced similar kind of strategy and problems across the world. First thing is it impacted those who are more disadvantaged than others. So there's level of disparity between how it impacted, whether it is in the older population, in the minorities, in the socially disadvantaged, and also in countries with lower resources like Thailand. How going forward is very interesting. Like Professor McDermott said, the problem, the COVID, might not be an acute. It isn't one-off. We have not seen evidence that it is going to go away anytime soon. But it might become a chronic problem, producing a lot of psychological impact. Let's say aftershock after this. How then, as mental health community, do we tackle the fallout that is going to come? With Dr. Lee talking about using virtual reality, I was thinking, or maybe this might be one of the possible ways in tackling the COVID-19 with the social distancing and everything. Could we use newer technologies in mental health like virtual reality, AI, web-based therapy to help, especially in lower resources settings? Secondly, where would this intervention be needed most, or when? How? If, like Professor McDermott said, it's going to be chronic disaster. When is the optimal time for us to go in as a mental health provider? And looking forward from Dr. Hughes' talk, if economic impact is going to be huge across the world, how then do we manage? If the government cannot provide the funding that we need, how could we care for those people who are more disadvantaged than the others? And also, similarly, how do we then, as even lower resource setting in Thailand, do this? I'm going to throw that to the panel first and see what ideas could come up, please.
พรีเซนต์ตัวนี้ขึ้นมาเพื่อที่จะดูว่ามีไอเดียอะไรที่จะเกิดขึ้นมาจากการพรีเซนต์ตัวนี้ได้บ้างนะครับ
Okay. Sarah, I might go first. Look, I thought the last speaker was wonderful, and I think there's a lot of really, really good ideas there. I mean, from a technical point of view, what you're looking to do, you've got a universal stress. So you're looking for something that is high reach, low intensity, low cost. Doesn't matter if you're you're a wealthy country or not a wealthy country. You're looking at increasing the reach of your interventions. And I think a lot of those online possibilities are really very, very promising and starting to have really good evidence of effect. One of the problems, of course, with those is that the lower socioeconomic class or the more disadvantaged or the more minority or whatever, the lower access you have to online interventions. It's a catch-22. You can't afford a laptop or a computer and stuff like that. And that's why I think we need to remember some of the things that, Wendy was talking about. I mean, a lot of the best mental health on the planet is by parents doing good parenting and friends being supportive and, reaching out and being socially connected and doing things together like community gardening. I think it's an opportunity for us to be, to move away from a very strict medical model and to be much more holistic about what we consider as a mental health intervention. This is an opportunity for, for us to embrace that.
Yes, and I would agree with that. Really, I think whilst we've really got to amplify these digital solutions, because I agree that they're absolutely very quickly demonstrating results and significant impact, particularly for children, young people, and other groups like the LGBTQ community, particularly who will find their tribe online, if you like. So I think that again, some of this learning came before the pandemic. So some of these things we actually have known for a long time. I also agree that we need to shift from an overly medicalized approach, and some of the things that we know have saved people's lives over the last 5 months have been community support networks, have been extended families using all sorts of creative ways of maintaining that social contact. I think we've seen, young people develop new intuitive ways of staying in touch with their, friends and family. We've seen a huge amount of creative output, on various, platforms. The volume of extraordinary TikToks around the world, both have been a creative outlet, but also as an action of support. They have also allowed people to be activists, so allowing people to amplify their own voices and be heard in all sorts of different places. So I think this is an opportunity where I think we can engage governments and services and communities in this idea of a new social contract, a new way of thinking and being, less dependent on highly medicalized approaches. If we can't do it now, I think we probably won't ever be able to do it, because this is really the time and the opportunity to galvanize some of those mechanisms.
Yes, I agree that we all know creativity is positively associated with psychological well-being. So as mental health practitioners or researchers, I think we need to be creative as well. And also, we all know prevention is much, much better than intervention. Will largely reduce the cost. And in the last presenters talk about the cultural beliefs. And actually, in my research, 2 research projects related to COVID-19, mental health COVID-19. One is longitudinal one. Yesterday, I reported, but I didn't mention the filial piety as well. Actually, for us, we look at the longitudinal one. We found across 3 times, we are going to have another team coming in this, collecting the data this month. So in the previous 3 times, we found filial piety, cultural belief to care about our parents, and to comply to the government instruction, and across 3 times positively related to mental health and psychological well-being. So I think that may be something we can consider in the future when we develop prevention programs to utilize the cultural resources to enhance the mental health to combat against pandemic or other crises as well. And we look at, after we have the 3 times look at the filial piety, then we try to see whether for those people living in high infected area, in China we use time, or moderated infected area, or mild infected areas. We found filial piety again is a positive factor for preventing mental disorder. That may be something we can consider as well, particularly for people living in Asian countries, because we use mental health models from Western countries, but we have our own resources to use as well.
Well, and for me, in my own experience, we found that developing low-intensity intervention is very challenging for clinicians, because generally we are familiar with clinical intervention, we're familiar with comprehensive intervention. But when we have to modify it to be a simple and easy, some of our colleagues may believe that it is ineffective because it is too easy. So that's as a result, I found fewer research on low-intensity intervention. So it is quite challenging for people who work in public mental health areas that if we want to deploy or implement low-intensity intervention, it is quite hard for us to identify which is the effective or evidence-based low-intensity intervention. So I think the research in this area should be supported more, and it will be more effective, and it will have a huge impact on more people around the world. Yes, that's the point that I'd like to raise.
So if I could just add something on that, I mean, one of the great things about Beyond Blue is there's not a lot of professors of psychiatry in Beyond Blue. There's a lot of consumers, there's a lot of young people, there's a lot of marketing and IT people. And these people are incredibly creative, and they are very good at developing those kind of online low-intensity interventions where, you know, a lot of, at the other end of the profession is more, you know, tied into, much more costly, intensive, hard to roll out intervention. So, you know, I think that a lot of the solutions are not in the mental health workforce. And by the way, one other thing I'd like to say is I think one public health intervention we can encourage is that, you know, the online world at the moment is full of incredible negativity for obvious reasons, but trying to find positive stories, and we know they're out there, we know that communities are doing wonderful things, can be actually quite difficult. And there's a lot of people who are overwhelmed with negativity from climate change, from various countries struggling with political systems, with COVID. And I think there is, we need to encourage our society and our media and our government to remember the power of optimism and to remember the power of people rising above current challenges. I think that it sounds cliche, but we could do with more positive stories at the moment.
And I think just to add about that point around the solutions aren't necessarily in the mental health workforce, and I would add probably certainly not in psychiatry, in terms of the community experience. I think there is a challenge for us across the world to really think about how public sector, how NGOs, how we engage the commercial sector in a much more kind of systemic, creative way. We have some really good evidence of that, certainly in the UK in the digital space. We're working really well with some key digital providers, thinking about Shout as an example, who has, developed over the last 2 years, using a workforce, a global workforce to provide services in the UK, 24/7. And that's an extraordinary, commercial and NGO, integrated approach. And so I think that we've got lots of evidence where it works well. I agree that we're stuck in a bit of a time warp of sitting in the problem sometimes, and we really need to think about the solutions which are out there. The issue is about scaling up, and the issue is about making sure that they are localized, that we don't just take an approach that helicopters one thing into another area just because we think it's good enough. And that leads to the point around co-production and making sure that people who are receiving the services, who are in communities, are at the heart of deciding what happens next. So it's really all well and good. This is a professional panel here today, and that's really important. But we also need to remember that those people who are using our services really probably know much more than we do around various aspects of not only their own lives but their communities' lives.
So, Sarah, by the way, I was very worried the comments you made about the loss of NGOs in the UK.
Yes.
This talks to exactly what we're talking about. A lot of the non-medical model and a lot of social connectedness, which Wendy's been talking about, is championed and facilitated and beautifully run by NGOs. So, I mean, I think this is a double jeopardy kind of issue.
Yeah, it's absolutely a double jeopardy issue. I think that's a really helpful way of thinking about it. But I don't know if it's the same in Australia, but we've seen, I mean, it's been quite shocking, and it's affected mainly those that are at the grassroots level, although, certainly the big NGOs have also suffered. But we're seeing, certainly those charities who provide services or support, who cultivate that community experience, particularly for Black and minority ethnic groups, have just disappeared overnight, and it's an absolute devastating outcome of COVID. Civil society is in trouble, I think, in the UK.
I think on that a little bit depressing note, I have to stop everyone, but thank you so much for your talk. But I wish things would get better. Just yesterday, I just read the news that the Bank of England said the really bad forecast on economy might not be as bad as feared. So hopefully, since we are, and it's very bright in London today, which is quite rare. So
37 today in the UK, very warm.
Yeah, so I think there might be silver lining for us all as the global community. And thank you so much for your very enlightening talk. Dr. Lee, Professor McDermott, Dr. Hughes, Dr. Dussadi. And I have to end the talk here. Sorry to allow you to talk a little bit over time. Thank you.
Thank you. Bye.
Bye.
Thank you again. Bye-bye, everybody.
Care.
Bye.
Thank you very much, Dr. Sutha. And that's all for
Thank
this
you
session.
so much. I'm going to leave.
It's very insightful talk, and it's very well.
Yes, and it's really impressive that today international session went very well and really smoothly.
QR code เลยไหมคะ
Okay, before we leave the session, I would like all participants evaluate us as the link or the QR code show on the screen.
ประชุมครั้งนี้นะครับที่
And we would appreciate all of your comments that benefit and improve us in the future conference. After you have done the evaluation, you will get a certificate that you have joined the international session. Thank you very much in advance.
เข้ามาประเมินนะ
Yes, and we have one more international session left at 3:30 with the top with special remark with the topic of what we have done and what we should do by the invite speakers from World Health Organization and Ministry of Public Health Thailand.
นะครับ
Okay, thank you for your full attention. ขอบคุณครับ
ขอบคุณค่ะ